Thank you for joining us. Of course, this is the big topic of the time. We're at a very delicate juncture where cases are going up, the infection is rising at the same time as the vaccine is being rolled out. And there's much to be discussed, there's much to hear. People are seeking advice, and therefore we're not only delighted to welcome, but also very grateful to have the experience, thoughts of Professor David Katz, our very own, and his friend and colleague, Dr. Ellis Friedman, to guide us through, to navigate the times for us. The format is that they're going to share some of their thoughts as introductory remarks, and then there'll be time for Q&A. And when David and I discussed the title for this evening, he suggested something along the lines of, what will the virus and vaccine be doing over New Year's weekend? Illustrating the fact that this is changing so rapidly that, of course, we want to look to the future, and we have so many questions about what's coming up, but things are changing all the time. And so with that, David, I hand over to you, and perhaps you'll take us on from there. Thank you so much, both to you and Ellis.
Well, thank you very much for organising this, and we're I'm quite stunned by the numbers. You know, kind of these numbers in Limud, which are going on now, are not matched in many sessions. So it's fascinating to see, and maybe it's a compliment. I don't know. Just a little bit of background. I'm Emeritus Professor of Immunopathology, still active at University College London. I also do some work in the British Medical Association, and I'm chairman of the Jewish Medical Association, and relevant to this, I do some interfaith work, which might crop up during the discussion. Introducing Ellis is very easy because we see each other in our other hat in the British Medical Association very often. I've known Ellis for several years now as an expert on public health, but somebody who thinks very deeply about public health and the implications of public health and how they can be exploited in medicine. And it's been a pleasure and a privilege to have him as a colleague, and to also I also persuaded him before to do the first Jewish Medical Association talk on the subject of COVID-19. And people are still talking about that, and talking about the clear impressions he gave in June as to what was going to happen coming along. So when Ellie asked me about this, I said, I mustn't do it on my own. I must do it with a companion, and he is the ideal companion for this. Now,
thank you for that intro. Can I just pause for a moment to say I'm going to mute all once again, because some people have become unmuted, but in that process, you're going to be muted. So just give me a moment. I'll mute all and then unmute yourself to begin again. Thank you. Oh, hang on a second. I'm going to make you a co-host that you can unmute yourself, and the same for Ellis. How's that?
David, you need to unmute.
Okay. Is that not working for you, David? Let me try something else. Oh,
He should
the rescue.
He should be able to unmute.
there we are. Okay, not my machine. Okay, right. Is that all right? Can you hear me, see me?
Yes, thank you.
Okay, right. So thank you, Jean. So in the immunopathology role, I've been interested in vaccines all my working life. The Jewish aspects of vaccines actually go back long before my working life. The first Jewish reaction, and almost the first faith reaction to vaccines, was in 1785, when a rabbi in London was one of the first people to endorse vaccination against smallpox. He'd lost 2 children to smallpox, and he wanted people to adopt the new scientific method of handling smallpox to prevent smallpox. And that's a very basic kind of response in Judaism. It's a very basic issue, and it's one that, you know, follows through to this day. There's a history of Jewish involvement in vaccination also in the early part of the 20th century. There was a maverick Jew from Odessa who devised a cholera vaccine, which was extremely successful, but unfortunately he had medico-legal problems, and he ended his life becoming a very Orthodox Jew, no longer practicing medicine in Switzerland. So there's a background history, but there's a background history also, and in the understanding of in fact, what are we aiming at? What is vaccine, and what is the objective? And the objective basically is that not that you free from the infection, but you give the person something that when the infection is transmitted to them, the body knows immediately how to handle it. And that's a very key point. So, and the key factors that you need to remember in that are that, first of all, this invader needs to be identified, recognized as something that's foreign, and then the immune system needs to check in and check in, and it has 2 ways of reacting to it from an immune point of view. First of all, it's the innate, the cells that are circulating in the white blood cells, and then it's the adaptive. It's innate is not specific, but the adaptive is the specific. And again, in the adaptive, basically, there are 2 ways of adaptive working. One is to make something that you secrete, which is antibody, which is an antibody against something that's come in. And the other, only defined in the last 50 years of the last century, rarely properly, is the T cell response. And the T cell response itself takes different forms. One form is to actually help to make antibody, and the other form is to kill cells that are infected. And the 2 work in synergy, and they produce things called cytokines, which are the kind of hormones of the immune system, which act and help them along the way and guide the rest of the immune system along. So those are the things you're trying to achieve. The other basic thing you're trying to remember about achieving is that the initial antibody response is a large antibody, IgM, and then afterwards, after that, you get a second wave, which is the IgG, which is a smaller immunoglobulin molecules, but they're much, much more specific. They're much better, and they come along a little later. So this is the basic mechanism that you use to respond to any infection. Most of the time, it's successful. It gets rid of it, handles it, if you've recognized and you've done this. The nice thing about the immune system is that apart from the brain, it's the only other system in the body that has what is called memory. It remembers. So the immune system is remembering what has happened before and is therefore able to respond much better. And what you're doing with a vaccine is you're attempting to achieve that kind of response. Now, jumping forward to the into the 1930s, 1940s, although I've already delved into the latter part of the century, of course, but jumping a little forward, you know, there is some strange stories about immunization relating to Jews. One of my own personal favorites was one because I knew the person involved was everybody's heard of Wingate, and everybody's heard of his conquest of Ethiopia, Abyssinia, reconquest in 1943. What's little known is that, of course, they needed to immunize the Ethiopian soldiers that were coming in. They needed to vaccinate them. Now, the vaccination could take place to all the troops and so on from Ethiopia that were taking part in this parade, going in famous parade of Wingate going to Ethiopia. If you look at the pictures of that famous parade, you'll see a little man standing behind a small little Jewish man who was in fact a Polish doctor who had qualified in Italy, was living in Palestine, was seconded to the British Army in Cairo, and ended up going with Wingate. And he was the man who was responsible for immunizing Haile Selassie, which is quite difficult because you couldn't expose the backside of the emperor of Ethiopia. And so, although he could immunize all the others normally, Haile Selassie, he had to immunize through his trousers. And now the net result of this was that, of course, Haile Selassie had a very good innate immune response because he had all sorts of other things injected into him. And he had very sore buttocks, whereas the rest of the troops, of course, had very, very minor pain from the injection. Now that's the difference between innate immunity, because he's getting inflammation going on there because of all the other things that other things that are injected as little bits of his trousers went in with the immunization. We have no record whether Evie got yellow fever as a result, but yeah, as a result, if he didn't get yellow fever, that was obviously successful. Now, all of us know quite a lot about vaccination. We know quite a lot about vaccination from personal experience. We know about the diphtheria, tetanus, and whooping cough, and we know that children get that. But those ones require booster doses. Remember, it's more than one dose. You need more than one dose. Those ones are made from a toxin, from something dangerous that the organism produces, and then you make an antibody against that. Pertussis acts as a carrier for the others. It helps the others when you give it together. That's against a bacteria. So that's one example. They have other vaccines can have very long-lasting effects. Other vaccines are renewable every year. The flu vaccine is renewable every year. Other vaccines, the papillomavirus vaccine, we know that some countries use one kind and other countries use another kind from a different manufacturer, and there's slight differences and there's arguments all the time as to which is better. All of us know about the MMR vaccine, the measles, mumps, rubella vaccine. That is a form of vaccine where the organism itself is taken and is what's called attenuated. It's made weaker. So if people who have problems with their immune system are advised not necessarily to take it. We don't often analyze these kinds of things in the kind of detail that we're analyzing COVID-19. Mumps is a known cause of male infertility if you get it as a teenager or a young adult. The net result of the measles, mumps, rubella opposition, the anti-vaccine part of against that vaccine, is that there have been outbreaks of mumps amongst teenage boys who are at school together in recent years, which should never have happened. And so you can have unexpected consequences of the failure to accept vaccination. Hepatitis B virus vaccine is the most important probably of what's called recombinant vaccine. It's a vaccine that's made totally synthetically. You put the little bit of the sequence of the particular hepatitis B antigen into another carrier. That goes into cells. The cells make large amounts of the antigen like factories, and then you inject them into people, and the people make antibodies against that. And for years, I've had to work with Hebra Kadisha to actually make sure that the hepatitis B vaccine is good enough for them to continue doing their activities. And these are all different kinds of vaccines. Now, what has happened here? What has happened here is that 200 companies, 200 organizations in the world tried very hard immediately to make a vaccine against COVID-19, against the what's called the SARS-CoV-2 virus. They knew that they were working against the odds because the coronaviruses, the previous vaccines in the previous outbreaks had not been successful. They knew that some new strategy needed to be devised. And that is the reason why we're hearing about an entirely new method. Now, the RNA method of making vaccines is in fact 32 years old. It's the middle 1980s that the idea came up that if you could get RNA into a person and get the person's own cells to make the RNA into a protein, that would be a good way of actually making cells make something for immunization. The other thing is that if you could get RNA that's orientated the wrong way, that's not in the right sequence, but is in the wrong sequence, you could maybe block things and block things that are promoting, for example, the growth of tumors. So there was the sense RNA and the antisense RNA fields. And like many other people, I worked in that field for a number of years. And the big problem was delivery. How do you deliver the RNA into the cell that it gets into all of them, in the case of a tumor, or it gets into the right ones, or it gets in the right way that it doesn't get chewed up like a foreign body, so that the RNA molecule survives sufficiently well to get into the cell and to actually produce the right protein that will then act as an immunogen, will induce an immune response like any other like any of the other vaccines that we know and love. But because the other coronaviruses had not worked with any others, this was regarded as a good one to try. So this is the one branch that we're looking at the moment. And the other branch is, of course, the Oxford one, which is coming up, which is in doing an entirely different technology. So the RNA one has been a remarkable achievement when you think about it. We know the sequence of the virus almost immediately. And Ellis is going to comment a little bit about mutants and about new variants. We knew the sequence already, so we knew, there was a famous saying in the 1970s saying DNA makes RNA, RNA makes protein, protein makes money. That was the saying then. You could say RNA makes protein, and protein makes antibodies and T cells, and that whole process makes money, which is why there's so much commercial interest in this. Now we're actually looking at the moment at the RNA. I just want to focus for a few minutes just on that. This is an RNA that's been packaged into tiny nanoparticles of lipid. And the tiny nanoparticles of lipid need all these extraordinary conditions that we hear about to actually stabilize it and enable it to get into the cell and to survive in order to be able to translate into protein so that the cells of the body can make this protein. It's a new protein. They haven't seen it before. They can make antibodies and T cells, and they can therefore react against any cells that become infected. And this is a huge achievement in a very short space of time. And subsequently, what has happened is that they've done trials, and the MHRA recognized this because it had sufficient complete data to be able to say that the safety was there. Now, there's one last point about that safety that you need to actually take into account at this point is that if you've got this going in safely, we've got an interesting situation. In October, and Ellis may remember my saying this, in October, we said that if we use natural spread, if we use natural spread, we may be able to, if we do badly, we'll get the results in February, March of the first big batches of immunization with this route. If we do badly, if we do well in our lockdown, if we eliminate all spread of infection during April, May, June, then we're only going to get our results from this experiment with this vaccine in April, May. Unfortunately, it's the first option that the country, for one reason or another, has ended up having to follow. So we're getting the results in February, March, rather than April, May. If we'd done much better on lockdown earlier, the results would have been delayed. So I think I'll hand over on that rather sad note to Ellis.
Well, thank you, David, and thank you for this invitation to all of you, and thanks to David for the kind introduction he made. I'm not intending to speak for too long, although I might need to look at the watch to make sure I don't overrun my time, because it's very easy to speak. It's such a large topic, but I'm going to try to just give an overview of where we are at the moment, because what's most interesting for me as somebody who's been giving advice on COVID for a long period of time now is to hear what people's questions are. As David has said, I've been giving advice to the BMA on the so-called expert advisory committee that they have. I'm one of the many advisors to the Department of Health, unpaid, I should add. I, like David, took my pension some while ago, but I've been particularly busy for the last 9 or so months because people like me have been in quite large demand to be offering advice, hopefully critical friend advice as to what we should be doing with this pandemic. So to start off with then, just to remind you that this is a global pandemic, and that's basically because this virus was a new virus to humans, and none of us have any innate resistance to it. And that means that it has spread across the world. Now, at the present time, we're in an interesting phase of the pandemic in that if one is looking at it in terms of glass half full or half empty, the glass half full is that, as you've heard, we have 2 vaccines that have already been given approval for use, and we're expecting a 3rd, the so-called Oxford vaccine, to be approved for use very soon. And so that is the good news about looking to the future. But at the same time, the virus is now at a dangerous stage in many parts of the world, including the UK. Now, I'm saying it in most parts of the world because it's important to recognize, in terms of controlling the virus and controlling the spread of the virus, that the UK is actually amongst the worst in the world in terms of its record, and that other parts of the world have got a very good record. And that's in particular a lot of Southeast Asia, Taiwan, China, New Zealand, Australasia. And that's for a number of reasons, but predominantly it's because they've followed what I would call the elimination strategy. You can find some of the things that I and others have written on this if you want to look at it. But basically what they did was they tried to eliminate as far as possible all the virus from the country, and then they imposed very strict controls on people coming in and out of the country to basically try to stop the re-emergence of the virus in that country. And I've been proposing that as what the UK should have done since about May. And I don't think there's almost any epidemiologists in the world now who don't think that that would have been the best strategy, not just in terms of the health consequences, which would have been obviously much better, So, for example, in New Zealand, they've still not had 100 deaths. But also, all of the economies in the world that have gone for the elimination strategy have done far better than those who've avoided trying to do it because they felt it was going to be advantageous to their economy. So I mention that because I think it's important that one sees it in context in terms of what could have been. But we are where we are in the UK. And in the UK, we are now experiencing a form of the virus which is more contagious. And this is the so-called variant that we found in the UK. There is another variant that some of you will have heard of, which seems to have started in South Africa as well. And this is not surprising. We've seen many different variants of the virus over the last 9, 10, 11 months, depending on when you want to say that this pandemic started, because all viruses are mutating all the time. And when the virus finds a mutation which adds an advantage to it, that new strain generally supplants the older strains quite quickly. Now, this new strain is clearly more contagious. In other words, it's easier for you to get infected by it, but our knowledge at the moment of this new variant, and indeed the South African variant as well, is it's no more virulent. In other words, it's not more likely to cause more severe disease if you get the virus. But clearly, the number of cases that we're now experiencing in the UK is at the highest level that we've ever had. Now, clearly, that's partly because we're testing more, but we've now unfortunately reached a level of demand on hospital beds which is greater than in the first peak. And so it looks as if we are going to get more cases coming to hospital and possibly even more deaths than we had in the first wave. I say possibly because treatment has improved since the first wave, and so you're less likely to die now than in the first wave. So even though there are going to be more cases hospitalized in this wave, that won't necessarily mean that we have higher numbers of people dying in the first wave. But nonetheless, there will be very significant numbers of people dying. And it is inevitable already that the number of cases that we see in hospitals will increase, because this latest record that we've had today of over 40,000 cases will in about 10 days' time to 2 weeks' time translate into more people being seen in hospital. So that's the bad news, which is that there's going to be more pressure on hospitals, and that will mean almost inevitably that in order to cope with that influx of cases, we're going to have to further defer some of the more routine work in the NHS. And there are already enormous waiting lists in the NHS, and those will be further increased. That's not because we don't have spare capacity in things like the Nightingale hospitals. It's that we have a finite amount of staff. And because of that, because the numbers are so great, we're having to transfer hospital staff, basically, doctors and nurses, into treating COVID patients rather than non-COVID patients. So how do I see that the next few months progressing? Well, on the one hand, we are going to see a difficult couple of months in terms of the number of cases increasing. Now, what we can do about that, you have seen to some extent by what the individual governments in the UK have done, which is to basically increase the number of restrictions on our daily lives. So that at the moment in England, for example, the majority of the population is now in so-called tier 4. Now, do I and others think that this will be enough? The answer is no, it probably will not be enough. The single most useful thing that could be done, in addition to what we have at the moment, is to have more closures of schools, because it's schools that are the main way in which the infection is being spread throughout the community. And that would be the single easiest thing that the government could do to reduce the spread of the infection. Whether they will do that, of course, is a political decision. And I well know as an advisor that much of my advice, although very sound in scientific and medical sense, has not necessarily been accepted by the Centre for political reasons. And obviously the politicians ultimately are making the decisions as to what to do. But I would expect that more of the population will be put into tier 4 over the next couple of months. At the same time, what clearly needs to happen is for the vaccine rollout to happen as quickly as possible. Now, for that to happen, we basically need to have the Oxford virus being approved by the medical regulator, and there's a tremendous amount of confidence that that's going to happen this week. So hopefully that step will be a tick in the box very quickly. Now, the Oxford virus is the one which the UK government have purchased the most doses of, 100 million doses, which is basically enough for the population of the country. And so the rate determining step will be how quickly the Oxford vaccine, and indeed the other vaccines that we've ordered, how quickly the manufacturing of those vaccines can take place, such that we can then roll out the vaccination program as quickly as possible. Now, the current government plan would mean that those at highest risk will all have been done. That's the 2 doses of the vaccine 3 weeks apart. They will all have been done by about the end of March. I'll come on to who are the highest risk in a minute or two. The intention is now to try to speed up that process. And as long as the vaccine can be manufactured quickly enough, that should mean that we could actually bring that forward by about a month to the end of February. So by the end of February, it is potentially possible that the highest risk people will have all been immunized. Now, who are the roughly 15 million people in this country that are highest risk? Well, they're highest risk because they are most likely to get hospitalized and unfortunately to die. And so basically that 15 million people is everybody aged over the age of 60, everybody with specific underlying conditions more likely to cause an adverse reaction if you get the disease, NHS staff and care home staff. And so there is the potential, with the caveats I've given, that we could be in the situation where we vaccinated all of those people by, let's say, the start of March, which would mean that we would then see quite steep falls in the number of people being admitted to hospital and indeed dying in hospital from April. So again, that's the optimistic scenario. That also depends, of course, on the compliance with the vaccine, right? Now, some countries more than others, it appears that there may be a number of people who don't want to have the vaccine. Amongst the high risk groups that I've mentioned, in other words, that 15 million, the indications are at the moment that over 80% of those people offered the vaccine will take it, which is a higher percentage than the general population. And so if that does happen, that will mean that we will have a pretty good response in terms of the effect on deaths and on the impact on the hospitals. We won't have reached what is called herd immunity. I won't explain exactly what that is for quite a period longer than that, because the disease is more infectious than it used to be because of the new variant. And so probably you need to have 70 to 80% of the population vaccinated before you get to herd immunity. And given the number of people who probably will refuse to be vaccinated, we probably won't reach that level of immunization coverage until, well, probably at the earliest July or August. So there will be some need, depending on how cautious the government is, for some restrictions on daily living, but nowhere near as severe as we've been experiencing up to now. So overall, I'm reasonably optimistic about the situation that we're in. Of course, I regret some of the decisions that have been made to get to the situation we're in at the moment, but things are looking better. So lastly, I just wanted to say that clearly there's a concern that the new variant won't respond to the vaccines. Our view at the moment is we can't know for certain that that's not the case, but we think it's very unlikely. So the spike protein, many of you will have heard about, which is basically how most of these vaccines work, even though some of the variant does affect the spike protein, we don't think that it will stop the vaccine working effectively. We also, in terms of knowing enough to know what the policy should be, we know from all of the vaccine trials so far published that nobody who's got the vaccine has needed to be hospitalized or has died. However, a small percentage, larger with the Oxford vaccine, have developed the disease mildly, either asymptomatically or with some symptoms. Now, that doesn't matter too much for them because it's a limited disease, but we also don't know whether such people will then be able to pass the disease on to others. And clearly that's something that one would want to know in terms of being able to determine future policy. But we don't know that yet. We also don't know how long the vaccine will be effective for. Quite a lot are being cautious and saying 1 year. My look at the literature makes me feel that it might be that the vaccine will actually last longer, maybe 2 to 5 years even. But clearly, these are things that we will only know over time. But again, they are source for some hope. And one should say, with the novel ways in which these 2 new vaccines that have been approved have been manufactured, as David's tried to outline to you, it would, in theory, be quite a quick process to be able to create a new vaccine corresponding to the genetic information of the new virus. And that, in theory, could be done as quickly as 5 or 6 weeks. So even with the pessimistic scenario that a new variant emerged that wasn't, where the current vaccine wasn't so effective, we would have the technology to be able to produce a new effective vaccine relatively quickly. But I think with that, I'll stop and hopefully have done enough to stimulate some questions for you. The other thing I wanted to say is that I'm speaking from Stanmore, and you've got a person who is an attender of Stanmore Shaw who's talking to you.
Fantastic, and thank you. Welcome to everyone from everywhere. Fascinating. The numbers have continued to go up, not just in terms of the infection rates, but the people joining this evening, and that's a positive thing. And people have been messaging me to say how interesting they're finding it. So thank you. I'm now going to open the floor for questions. In a moment, I'll give you the ability to unmute, so you can unmute yourselves and vocalize your questions if you wish to. Otherwise, you could pop them in the chat box. Just put it to everyone or to me specifically, and I'll pass it on to David and Ellis. There were some questions submitted beforehand. I believe that you've pretty much dealt with those, other than the one about whether all the vaccines are appropriate for every age group. Is the Oxford one also going to be okay for 65 plus?
Yes. The thing that we don't know about the Oxford vaccine is that with the other vaccines, they were over 90% effective. The Oxford vaccine overall was 62% effective, and that rose to a much higher figure in a subgroup that had a lower dosage of the vaccine initially. But that was achieved in people who all were under the age of 55. And so that has left a little bit of doubt in terms of whether there is any reduction in effectiveness of the Oxford vaccine amongst older people. I suspect that there won't be, but we're waiting for some more information on that point.
Thank you. So questions to either David or Ellis, both of you, either of you, however you want to answer. There are a couple more that I've already received. One says that there's been discussion about apparent fears in the community, amongst the Jewish community, that the virus may cause infertility.
Okay. This is yes.
Sorry, I'm not sure. It says the virus here, but it could be the virus or the vaccine.
It's the vaccine. It's the vaccine. The vaccine causing infertility.
Wasn't me, David. That
sorry.
wasn't me.
The vaccine causing infertility. Leaving aside at the moment the vaccine's being given to people who are over 80, so I'm not so sure it's such a problem. Wouldn't be such a problem. I deliberately alluded to the Mumps story because the Mumps does cause infertility in males, and the MMR, the failure to take vaccine and MMR and ignoring that fact was relevant. Okay, this is an urban myth that we've heard about from Israel. We've heard about it from America. A workman in the home of a friend of Jean's actually told her, former healthcare administrator, that exactly the same story. So it's not confined to the North London or Northwest or Northeast London Jewish community. First of all, it's not true. There, vaccine causing infertility and knowing about it within about 2 weeks of its introduction is incomprehensible. The possibility of it getting anywhere near the germ cells is even less likely than the knowing about it. And really, unfortunately, it's part of a syndrome. It's part of the syndrome of anti-vaccination propaganda that's out there. And, and Donald Trump is responsible for many things, but this is also one of the things that he's been very active in promoting, the anti-vaccination lobby. So the answer is it's out there, and the answer is no, it does not cause infertility.
Excellent. Sounds reassuring. Just taking the questions in the order that they've arrived. There's a question here from Kate Glick. She had the virus several months ago and tested positive for antibodies. She's now thinking about volunteering as a vaccinator for the NHS.
Yes.
That's the backstory. The question is, has the vaccine been tested on people who've already had the virus and have antibodies?
Do you want to answer, or I mean, they are included in the trials, but
they have been included in the trials, and so they're yes, they are eligible to have the vaccine, and indeed all of the evidence we have at the moment is that that would be the sensible thing to do, because we don't know how long immunity lasts from having the infection itself. Whereas, and we've got every reason to believe that the vaccine will confer longer lasting immunity than the natural immunity that one gets. So, but there is certainly no worries at all about giving the vaccine to somebody who's previously had the disease. So that's not a problem at all.
The advice is to have it.
Oh,
Yeah.
absolutely, yes, absolutely.
And another question just came up, the 62% effective. What does that mean? 38% ineffective. Yes, it means that 38% of that in that branch of the Oxford study, 38% it was not effective. It depends which vaccine you're comparing it with.
But do remember that 38%, even though, yes, they did get the disease, they didn't get it seriously. And so they had got some immunity from it, because none of them needed to go to hospital and nobody died. So even that 38% certainly did confer a benefit from being vaccinated.
Sure. Okay, thank you. Going back to your comments, Ellis, about schools, is that the reason why Tier 4 isn't working? Asks Mark.
Yeah, so there are two main reasons why Tier 4 isn't working. One is the schools, because we've got a lot of evidence to show that a lot of the spread of the disease is coming through schools, right? And so clearly making that policy decision, if one were to, of reducing the number of schools that were open, and there's a number of ways you could decide which schools to close. For example, ones that could not be easily well ventilated would be a reason for saying that particular school should close. That would be quite a good way of increasing the strictures in Tier 4 and making it more likely that they would work. The other reason is that we know with certainty that if people followed the basic rules that we've been talking about now for 9 months, in other words, keeping 2 meters apart and washing your hands, etc., wearing masks, if you were doing all of that, if everybody was doing that perfectly, you would not get the spread of the disease, right? In terms of the R being greater than 1. There would still be some spread, because there's quite a number of people who are asymptomatic and therefore spread the disease, even though they are adhering to the rules. I won't go into too much of the reasons why it won't go to absolutely zero, but basically the population has got frustrated with the rules. They've got bored with it, so, and that's not surprising, because we've had months of having to deal with a situation where we're acting abnormally. And so in most societies, what we found is that there's been a slow reduction in compliance. And so that's really the reason why the COVID restrictions haven't worked, is because people aren't obeying the rules as strictly as they should do. But some of that is understandable.
Sure. I think the population is also frustrated about how some of the logistics are being managed, and Sydney articulates this and asking, what was the point of building the Nightingales if there aren't enough staff?
Well, do you want to, the hospital, the Nightingales were created in order to give us more specialized beds, right? And so the intention of those Nightingale hospitals was to move the staff from non-COVID work into those new designated beds. Now, the reason why the Nightingale centres have not been used that much is also because when we were going down the route of building the Nightingale hospitals, the view at that time was that we needed a lot more ventilators and that ventilators were going to be extremely important in terms of management of the disease. Now, experience has now told us that that isn't true, and that only in quite a small subsection of people who get hospitalized is it actually advantageous for them to be treated on a ventilator. And therefore, that extra capacity of ventilators, which the Nightingale hospitals gave us, most of that is not needed.
Okay, thank you. The next series of questions relate to side effects. Are there any vaccines that are better for one thing or another, people who are allergic to penicillin and so on?
Okay, well, let's look at it. First of all, the allergic to penicillin is very easy. People with known allergies who carry an EpiPen are not advised to have the Pfizer vaccine. This is because a couple of people who were given it, not very many, had what was called which my grandson who falls into this category keeps on telling me, an anaphylactoid reaction. They had looks like it was anaphylaxis. So therefore they're advised not to have it. We don't know if it's a true allergy in the classic sense. They're all mild or moderate, except for one solitary isolated report in the United States. And again, then one doesn't quite know what the background of that, because it's not been published yet. So that is the one group that is perfectly clear. The other issue that relates to that vaccine is that there are fears that if it isn't handled properly, you can have a vaccine levatala. You can have a vaccine that is not fit for purpose. That doesn't actually work. So that's the second fear about that. The third, with regard to the Oxford, we don't know yet, and I have to be very careful about that, because I've spoken about the two that are in the public domain. The Pfizer, there was a huge submission to the FDA. You've read these documents are all out there, and I read that, had to read quite a lot of them. And they are if I say something here, it's not going to help an anti-vaccination lobby. It's not going to be translated into an anti-vaccination attitude. So one has to be very careful, because I haven't seen that kind of information as yet surrounding the Oxford vaccine. Now, the question about the Oxford vaccine is we don't know. We don't know whether the virus itself, you're given a chimpanzee virus, which has got a chimpanzee adenovirus, which has got the same sequence, the same protein coming out of it, as it were, that is the immunogen in the Pfizer one. You've got the same protein being produced, you're producing an immune response to that. But maybe you produce an immune response to the virus as well, and that may be helpful. Or it may, on the other hand, not be helpful. We don't know. And that's the kind of thing that will only emerge with time. And remember, anybody familiar with the polio story? The March of Dimes with polio was in the 1930s, and the vaccines were produced in the 1950s. We're talking about a scenario that we've had a vaccine produced, and a new kind of vaccine, a totally new kind of vaccine, as well as ones that have been of the type before, that has been produced within 1 year, which is a remarkable, really scientific and biomedical achievement to actually have got as far as we've got, and to be able to ask the question, what are the adverse side effects this quickly, is quite remarkable.
Okay, I think one of the big discussion points coming up in the questions is about expectations on delivery. Can the government meet its targets? What kind of insight can you offer? Should we be pushing for vaccinations to be delivered on the weekends and in the evenings in order to speed up the community uptake? And I guess tied in with that, how is Israel so far ahead? Anything we can glean from that? There is an interesting question going on in Israel, actually talking of weekends, about whether they can vaccinate on Shabbat. Is this seen as pikuach nefesh, saving a life, and therefore, of course, even Shabbat observant people should be vaccinated on Shabbat? Or is it just a stage before that? So without discussing the halachic element, nonetheless tying in Israel as an example of what's going on in the world, what's happening here in the UK, and how can we reach our targets as efficiently as possible?
Yes, so clearly, I have seen for some time the government's plans for the vaccination program, which includes not just about how you make sure that the vaccine is delivered, but it's also there's going to be a campaign to try to get people to accept the invitation to the vaccine. But I think, as I said before, that everybody can see the virtue of trying to speed up the delivery of the vaccine. And so the plans, which have not yet been finalized, which bring forward the so-called 15 million or thereabouts of the most at risk in the population, from them having been all being done by the end of March back to the end of February, that is going to be done by having more centres available, etc. Now, the Oxford vaccine has a great advantage in that it's much easier in terms of its storage, and the so-called cold chain of making sure it retains its effectiveness is far easier to control. Now, even though this government has often overpromised and underperformed, one would hope that with a vaccination program that we should have more realistic expectations that they will succeed, because we have major vaccination programs every year. And so hopefully that will mean that it will work. I think the major problem is likely to be that the manufacturing process is not as effective as we might like, and therefore the rate determining step is how quickly the vaccine can be produced, right? And we can't yet be certain about that. But certainly what the plans in this country will do is to basically increase the number of centres and the number of people who can give the vaccine. It's really not a very difficult process to train somebody to be able to give the vaccine. And so that won't be a rate determining step. So we should be able to do all of that. And to have achieved that by the end of February, I think is realistic. And in effect, that is what Israel and other countries are doing. I mean, obviously, Britain was the first country to start immunisation in the world. Israel has now started it. Obviously, Netanyahu himself has got immunised, etc. And, you know, like any sensible country, what Israel is doing is trying to get that vaccine delivered across the country as quickly as possible. And I think all countries will do that as long as they have been prudent, as Israel and England and the UK have been, in ordering enough of the vaccine. Clearly, some countries didn't do so. That was sometimes because of their economics. They couldn't afford to do it. Others simply weren't far-sighted enough to order the vaccine. But Britain, as long as the Oxford vaccine is approved, which I expect it to be this week, we have got sufficient on order to be able to do everybody, certainly all the high-risk ones, in the timetable I've mentioned.
Any sense in following the argument to do single doses for now, or was that senseless?
Well, the single doses is an interesting hypothetical idea. The difficulty is that the vaccines weren't tested using that particular format. And so we wouldn't be absolutely certain if we went for that strategy, whether that would be effective. Personally, I would stick to the 2 doses for those most at risk, but then having reached that scenario, let's say by the end of February, then it might well be sensible to do the 1 dose for particular high-risk groups, like, for example, university students, in order to try to reduce down the prevalence of the disease at that stage. But clearly our knowledge about this will be increasing all the time, but for the moment, that's my advice in terms of the way forward. As I say, the politicians don't always do things which us experts think are the best way forward, but that's what I will be saying to them. So for example, there's been a lot of talk about why, teachers should be a priority group. And frankly, I don't think there's much sense in that suggestion at all. Teachers rarely get infected at the moment. And if you just immunize the teachers, it would have very little impact on the amount of the disease that's occurring in schools. The school's transmission is between pupils. It's not between pupils and teachers mainly. And so that, I think, is not a good policy option. Doesn't mean it won't get done, but it wouldn't, to me, be a logical thing to do.
Great. That leads on to the questions we've received about children. To what degree are under 12-year-olds likely to be carriers of this new strain? Should we roll out mass testing for children? Is that even ethical? How about dealing with some of the issues relating to children returning to schools? Should we be cautious of having children in our community spaces? Even for those who don't have children in their own family, but they go to synagogue, as an example. How cautious and aware of this children's issue should we be?
Well, if I answer that, we had traditionally been most concerned with children over the age of 10, because the transmission in that group, let's say 10 to 18, was a lot higher than in younger children. Now, there is some suggestion that there is higher infectiousness amongst younger children with this new variant. We're not sure yet, but that is possible. Now, having said that, again, there's no suggestion at the moment that it's any more virulent in either younger or older children, so that's reassuring. But clearly, if children get the disease more easily, then they can spread it to groups that are more at risk. Their parents, but more worryingly, their grandparents, who may be in much higher risk groups. And so that's the worry about it. Now, this government, it was a Boris Johnson idea to save Christmas. I can hopefully tell you, even though this is being recorded. So this was what he called the Moonshot program a few months ago. And the idea was to rapidly increase the amount of testing capacity we had in this country so that we could do a lot of mass testing. And they started off in Liverpool, etc. This is not really an evidence-based idea. It doesn't have the principles of a screening program. Now, we have a lot of spare capacity, and we could use the so-called lateral flow tests in schools. And clearly, the government at the moment feels that there's a very high political priority in keeping schools open. And the way in which it wants to do that at the moment is by using mass testing in schools. The difficulty with that is that it's very difficult to know where you're going to have the trained people to do the testing in the schools. And then we also are quite dubious about how reliable the tests are in that age group. Well, in fact, in all age groups. And so there are some concerns about the reliability and the utility of mass testing at schools. And that is partly for that reason that I personally would feel that it would be a much easier, a much quicker option would be to basically have more children being taught at home, as we had earlier on in the pandemic, even though I accept that to do that, which might need to continue for 6 to 8 weeks perhaps, would obviously not be in the absolute best interests of the education of those children. But I think overall, it would be the best balance of pros and cons in my view.
Thank you.
Eddie, can I just comment about some of the questions that I noticed flashing by about
to finish the session in about 10 minutes or so.
Okay. Just some of the questions about access and which groups should be accessed and so on. I mean, one has to remember that, you know, the prioritization and the prioritization list is there. But the reality is that for example, very few care homes were reported yesterday as having had the distribution of the vaccine. The reason why this has happened is that there are very few care homes which would require 975 doses or 1,000 doses that you can get roughly out of one Pfizer package. So as a result, the number that have received them have been limited until some method can be worked out of splitting these boxes up into the smaller packages. So that's why they haven't received. The reason why some hospitals might have an excess one day and not an excess another day, and rumor gets out and people try and go there, is for exactly that kind of reason, that at the end of the day, there may be doses left over. That kind of thing is happening all the time. There is somewhat of a postcode lottery, because there are areas that were prioritized to receive on the basis of the population there at risk, felt to be at risk, or they had particular kinds of hospital wards that needed a high percentage. So there is a postcode lottery going on. Hopefully this will iron out over the next period of time. The question about the age, about the elderly versus the frontline workers. The frontline workers are important. The frontline workers are very important, and there's a huge controversy at the moment with the BAME community, because they say that their frontline workers had the bulk of the morbidity and mortality in the early stages. And, you know, should they be given a priority? Who should be given the priority with regard to the frontline work? Because there weren't deaths in the intensive care unit workers. There were deaths in ENT surgeons and in people in the secondary care. So there are huge issues about this distribution, which are there because we're in the early stages. Hopefully these are going to be ironed out, and quicker than other inequalities have been ironed out. They're international reasons. As Ellis said, people couldn't afford it. But, you know, they can, but countries couldn't afford it. But, you know, kind of certainly the AstraZeneca, there's been a commitment that this will be provided under an agreement, and there are agreements between the international agreements already in place to make sure that there is distribution into those parts of the world. You have to remember, though, that of course testing in those parts of the world is also case identification, and we don't know that there are different population dynamics in those kinds of countries. So these are all valid questions, but it's early days to know the real answers to them.
And if we line up the vaccines next to each other, would you say that one may be better than the other? And will the population know which one they're receiving when they go for the vaccine?
I think I explained that papillomavirus and shingles, the two conditions, there are competitive vaccines still going on. Polio has not been mentioned. Polio, you know, kind of it took I did mention it took nearly 20 years to get a vaccine from the height of the first as it were pandemic. Polio, there were two variants which were tried at the beginning. One eventually found favor. Again, the Sabin vaccine eventually found favor and is the one more widely used. This is not abnormal to have more than one vaccine going in the early stages until it stabilizes out.
Mm-hmm.
I mean, we just don't know yet. There probably will be differences in the effectiveness of the different vaccines, right? That's almost inevitable to be the case because we're using different technologies to develop them. Mm-hmm. Having said that, pragmatic.
Ellis, I think that's where the question's coming from.
So, but we are not pragmatically going to be given any choice, certainly in the first, let's say, 3 months, right? You know, hopefully I'm going to get vaccinated, right? I will have no choice as to whether I get Moderna, Pfizer, or Oxford, right? Now, having said that, it's only Oxford at the moment that looks like it's somewhat less effective than the other two. The Oxford people have been saying that the latest tranche of information that they've submitted, which I haven't seen yet, it may well be published in the next couple of weeks, they are claiming that that brings their effectiveness up to the same level as the other two. We will wait and see. Because that hasn't yet been published.
Okay, that's interesting. I guess we could probably just casually ask which vaccine we've been given, but they may tell us, they may not, and doesn't make a difference. We're not going to necessarily say, oh, no, stop, I'm not having that one, give me the other, please.
They tell you which one you've been given.
Okay.
You get a little card with the name of the vaccine on it.
Yes.
So you're given a little card to tell you you've had a vaccination. It tells you which vaccination you've had, and it also reminds you when your second shot is due. It's very, very, as an outsider, it was very, very organised. I couldn't have asked for better.
Can I just add one small point, Ellis? You will actually be told because the name of the vaccine is on the consent form for the Pfizer.
Yes.
So presumably.
No, you'll be told. But what you can't do, if I didn't make myself clear, is you cannot choose which vaccine you're going to have. That's the point I'm making. Yes, you definitely will know which of the different vaccines you happen to have. Yes, you of course need to have that information. But what you can't do is to choose which one of the three that are going to be initially available. And certainly I would not advise anybody to turn down the Oxford vaccine because they want to wait for the other two. That would not be a sensible thing to do.
Absolutely.
But if it's not suitable for 65 upward, then we'll have to turn it down, won't we, for over 65?
So let me make it clear. The Oxford vaccine has been tested on all age groups, and nobody who had the Oxford vaccine at any age needed to go to hospital, let alone die. So therefore, it conferred an advantage on everybody of that age group that was seen. However, 62% only had full protection. So 38% still did get the infection when challenged by the virus, but the infection caused either no symptoms or very mild symptoms, right? So it was still effective in the terms that are meaningful for people, because for most people, what's important is not whether or not they have the infection at all, but it's whether they have it to any degree of seriousness. And nobody basically had a serious illness having had the Oxford vaccine, and therefore it's fine. It may well turn out to be the case that with a variation of the dosage for the Oxford vaccine, that it's even more effective than the 62% achieved in the main part of their initial trial results.
David, anything to add?
I don't think there's really anything to add except the encouragement to people to accept to participate in the vaccine program. Questions like the anaphylaxis, which is supposed to affect 500,000 people in the country, 500,000 people in the country. When they're offered, they will be presumably will have a choice, because they will be immediately ticked off from receiving the Pfizer, and then they will have that is effectively exercising their choice, and they will presumably, if they're in an eligible group, will be called upon. I mean, the point is that when I've spoken to you about the material I prepared about this for the Jewish community. The issue is that all faith communities are facing the same problem, that there is this element of refusal and element of suspicion about it, and the suspicion about it in the Muslim community is enormous. Some people say only 1/4 of Muslims will actually accept the vaccine. So this is the reason why we work together with all the faith communities to produce an overview about the Pfizer, which you've got. And the take-home message is that, you know, we should be absolutely delighted about the fact that this vaccine is out there. And if you call to get it, it's important to get it, and also to encourage and to be positive about it, not to actually take a negative view about it. I think it's very important to recognize that.
Can I just say the other things about relative contraindications to the vaccines? The first one is pregnancy. None of these vaccines have been tested on pregnant women. And so for the moment, if you're pregnant, you won't be offered the vaccine. Now that they may well start testing it in pregnant people as part of the next phase of testing the vaccine. But for the moment, that is a relative contraindication to having the vaccine. And then if you are severely immunosuppressed, so for example, that might be with certain treatments for cancer, then that is a decision that will be taken by your clinician as to whether or not it's felt that on balance, you should or should not get the immunization.
Okay.
Any idea yet about what relaxation of the rules there'll be when we have been vaccinated?
Can we take that question? And then also Carol and Denise have had their hands up very patiently. And with that, we'll bring the evening to a close.
I didn't hear that question, I'm afraid. Maybe David did and can answer it, but I didn't hear the whole question.
Sorry.
You want it again? I
Yes.
asked,
Loretta, Carol and Denise, maybe we can have
relaxation of the rules will there be when we've had the vaccination?
Carol, Denise, do you want to ask your questions as well? And then maybe David and Ellis can wrap up. So the first question is about relaxation and the rules once people are vaccinated.
Yes, so clearly the relaxation of the rules, there's two possible answers. One is a scientific answer, and then there's a political answer. Let me try and explain. We've known for a long time that if you've had the disease, right, like, let's say like Boris Johnson, you've got lots of antibodies, and we know for certain that those are around for at least 3 months, and therefore you are not going to catch the disease in the next 3 months. Despite that, no governments decided that they would have a policy whereby they've actually said, if you've had the disease and have got clear proof, you can do the following things for the next 3 months. And they didn't want to do that for political reasons, right? One of the things I put forward, for example, about the Christmas policy, as advice to the Department of Health, was that anybody who had clear scientific evidence that they'd had the disease in the last 3 months, that they could actually join in the Christmas celebrations. Clearly, I was, you know, they were very, very anxious to try to make Christmas as normal as possible at that time, right? They decided to ignore that advice, not because of any lack of scientific knowledge, but because politically they didn't want to do it. Now, in the same way, there's a lot of things that you could do once you've had the 2 doses and a couple of weeks for the full benefit of the vaccination to take place. But whether that will become government policy is less clear, right? So I suspect that they probably will be cautious and keep asking people to maintain, you know, the social distancing, the masks and all the rest of it, even though the evidence would suggest that that probably is not strictly necessary.
Okay, so it'll be gradual. Carol?
Will all diabetics be in the at-risk category, and will they all be put forward in the list of getting the vaccine? What if you're younger?
Well, so exactly who is going to be considered high risk in terms of the immunization program has not yet been fully determined. It won't be everybody who is a diabetic, but it will certainly be, for example, I think all insulin dependent diabetics.
Thank you.
The one question raised recently about the diabetic if I could just add to that, has been the fact that the suggestion is that the age should be lower for type 2 diabetics. So we're talking about people over 60, but if that in the first wave, as it were, people over 70 who are diabetic should be included amongst the 80-year-olds. That's the concept that I've heard the diabetologists suggesting.
Yes, and it may well be that every diabetic aged over 50 is considered to be at higher risk and therefore will be done amongst 15 million. But again, this is sort of fine tuning that is taking place at the moment, and we don't yet have the definitive advice in this country. It's likely to be quite similar advice probably across the world ultimately, but for the moment, no government almost across the world has yet come up with that detail of decision making about what the policy should be.
Okay, Denise, finally.
Yes, thank you ever so much. I didn't quite hear what you said. Thank you both of you. It's been excellent, and I hope it's being recorded. David, I'm sure there are some deputies as well that may want to hear this, and Ellie. Ellis, can I just ask you, I didn't hear what you were saying about people who are allergic to penicillin, whether they can conclusively not have one or more of the emerging vaccines, whether there's definitive evidence that they shouldn't have. And what are the options for them?
It's only the Pfizer that this allergy has this anaphylactoid-like reaction. And the recommendation at the moment is that you shouldn't have the Pfizer. And when it comes along, there's no record that applies to the Oxford.
So, thank you very much. Thank you.
I would expect the Oxford one not to have that problem. The Moderna one, it might have a similar problem.
Yes.
It goes without saying that this has been extremely enlightening. A big yasher koach to both of you. Thank you very, very much for sharing, for doing everything that you do from Southampton, from Stanmore, and on behalf of the entire Jewish community, everything that we know about and all the things that we don't know about. We appreciate, we salute you, and not only that, but we treasure you. So thank you very much. Thank you everyone for participating. I think that's what it means when we say at the end of the book of Bereshit, as we will this week, Chazak, chazak, v'nit chazek, be strong, and let us be strengthened. We strengthen each other by being with one another, and Zoom can make that happen as well. So be well, be safe, and we'll see you all soon. Good night. Thank you very much.